What if the cure for a minor medical annoyance today became like the source of just debilitating, unexplainable agony 10 years from now?
Yeah.
Just imagine undergoing a seemingly straightforward, minimally invasive procedure to fix a really common issue,
Hmm.
like stress urinary incontinence.
Right. Something you think is just a routine, quick fix.
Exactly. You have the surgery, you recover, and you feel completely fine. You go about your life for 5, maybe even 10 years. But then, almost out of nowhere, you start developing this severe burning pain in your inner thigh. I mean, it becomes so intense that just walking down the street or sitting in a chair is agonizing.
It really is the ultimate medical bait and switch. You think you're entirely in the clear, and then a decade later, your body starts raising red flags that trace all the way back to that one day in the operating room.
Yeah, and that's exactly what we're getting into today. Welcome to today's deep dive, where we're investigating the highly complex world of transobturator tape slings.
Often referred to as TOT slings, yeah.
Right, TOT slings, and a truly debilitating condition that can follow them, known as obturator neuralgia. We're going to look closely at our sources to understand exactly how doctors evaluate this elusive, almost invisible pain and, the escalating steps they take to manage it.
Which is a fascinating process in itself.
It really is. So whether you work in healthcare or maybe you're advocating for a loved one dealing with chronic pain, or you just want to understand the incredibly complex wiring of the human body, this is going to fundamentally change how you view surgical implants. Because to understand how a surgery goes wrong a decade later, we have to look at the mechanics of what was actually implanted in that operating room. So what exactly is the architecture of a TOT sling?
Well, for that, we have to go back to the early 2000s, specifically around 2002 when this device was first introduced in the United States. It's a second-generation synthetic transvaginal mesh.
Okay, synthetic mesh.
Right. And its primary purpose is to treat stress urinary incontinence. That's the condition where physical movement, something as simple as coughing, laughing, or running, puts sudden pressure on the bladder, causing a person to leak urine.
Which, I mean, that is a huge quality of life issue for millions of women.
Absolutely.
And the physical mechanism there is that the urethra, the tube that carries urine out of the body, it loses its structural support. So the sling is meant to act as a supportive hammock to stop that leakage.
Exactly. The first generation version of this hammock was called the TBT, or retropubic sling. That one was threaded up behind the pubic bone. But the TOT, the transobturator tape, was designed as an alternative route to avoid injuring the bladder or the bowel during the insertion.
Which makes sense on paper.
Yeah, it does.
Mhm.
But the specific anatomical path of the TOT is crucial to understand here. The surgeon makes an incision inside the vagina, places the synthetic mesh underneath the urethra to support it, and then threads the 2 long arms of that mesh out through the groin.
Wait, out through the groin.
Yes. Specifically, they exit through the obturator foramen. It's a natural opening in the pelvis. So the mesh comes out right in the crease between the leg and the pelvis on both sides.
Wow. Okay, so it's anchored by threading it outward toward the legs rather than upward into the abdomen.
Exactly.
I mean, that placement seems totally logical for supporting the urethra. But it raises the most important question of our deep dive. If this is placed to help someone, and it works perfectly for years, why does it suddenly cause excruciating pain a decade later?
Well, the answer lies in the human body's foreign body response. The mesh used in these slings is a synthetic polymer. And when you introduce a synthetic material into the body, the immune system immediately recognizes it as an invader.
Because it's not supposed to be there.
Right. But because the mesh is too large for the body's white blood cells to destroy and clear away, the immune system just mounts a chronic, low-grade inflammatory reaction. It never stops fighting it. Over the course of years, specialized cells called fibroblasts continuously lay down collagen around the foreign material, eventually encasing it in thick scar tissue.
I think the best way to visualize this process is to picture a thin, flexible vine wrapping around a growing tree branch.
That's a great analogy.
Yeah,
Yep.
like in the beginning, the vine is pliable. It moves with the tree in the wind. It's barely noticeable. But over 5 or 10 years, that vine gets thicker and calcifies. It turns into a rigid, unyielding rope. Inside the human body, the synthetic mesh and that heavy scar tissue basically fuse together into a rigid, inflexible band.
Yes, and because the mesh is anchored deep in the muscles and membranes of the groin on both sides, the gradual tightening of that scar tissue creates a literal tug of war.
A tug of war inside the pelvis.
Exactly. You have this contracted, rigid band of mesh pulling immense tension between the delicate structures of the pelvis and the highly mobile structures of the groin.
And the human body is simply not engineered to have a rigid rope running horizontally through highly mobile areas like the hips and legs. I mean, there's a specific clinical case in our sources about a patient who sought treatment at Yale University Hospital.
Oh, yes, I remember that one.
Yeah, she experienced severe pain immediately after her mesh placement. When she went to her specialist begging for help, she was told definitively that the mesh could not be removed.
Which is terrifying.
Right, and she was sent to physical therapy. But she could only tolerate 2 weeks of that therapy because it actively made her agony worse. She was trying to rehabilitate the area, and the exercises were causing active trauma.
And that's because standard physical therapy exercises often exacerbate the tension in these specific cases. The underlying pathology isn't just a tight muscle that needs stretching. The problem is that nearby peripheral nerves are getting caught in the crossfire of this fibrotic tug of war.
Which brings us to the actual anatomical victim of this collateral damage, right? The obturator nerve. What is this specific nerve even doing down in the pelvis? And how does a hammock for the bladder end up tangling with it?
So the obturator nerve acts as a major communication cable for the lower body. It arises from the lumbar nerve roots in your lower spine. It travels down through the deep pelvis, passes through that exact same space called the obturator canal, and branches out into your inner thigh.
Okay.
And it serves two distinct functions. First, it provides sensory input feeling and touch to the skin of the medial thigh. And second, it provides the motor signals to your adductor muscles. Those are the powerful muscles you use to squeeze your legs together.
Oh, okay. So because this TOT mesh is routed directly through that specific anatomical doorway, the obturator canal, when it scars down and creates that tight band, it shares the exact same physical real estate as the nerve.
Yeah, it creates a massive conflict for space. And the entrapment can happen in two ways. There can be direct mechanical pressure where the dense scar tissue literally encases and crushes the nerve. Right. Or it can be indirect. The tension from the mesh causes the surrounding obturator internus muscle to go into a permanent defensive spasm. And that spasming muscle clamps down on the nerve. In either scenario, the nerve becomes highly inflamed and just stops functioning correctly.
So what does that physical entrapment actually translate to for the patient? Like, how do they differentiate nerve pain from just, I don't know, a severe pulled groin muscle?
Well, obturator nerve entrapment creates a very distinct clinical picture. Patients describe a deep, aching, or burning pain that originates in the groin and shoots down the inner thigh. Sometimes it radiates all the way to the knee.
Wow.
And because the nerve also controls movement, they'll experience noticeable weakness when trying to press their legs together. If they were trying to hold a heavy book or a soccer ball between their knees, they would really struggle to maintain the pressure.
Okay, that's a huge red flag.
Yeah.
Yeah.
Clinicians also look for a specific biomechanical trigger called the Hauschip-Romberg sign.
The Hauschip-Romberg sign. What physical movement triggers that?
The pain is significantly worsened when the patient extends their hip, meaning stretching the leg straight back behind them, and abducts it, which means moving the leg laterally away from the center of the body.
Oh, I see.
When you perform that specific combination of movements, you are pulling the already irritated obturator nerve taut, like a bowstring, across the rigid structures of the pelvis and the scarred-in mesh.
Wait, let me push back on this for a second. Because you're describing a patient experiencing severe, life-altering pelvic pain, especially when sitting down or moving certain ways. Doesn't that sound exactly like pudendal neuralgia?
Ah, good question.
Because that is arguably the most well-known nerve entrapment issue in the pelvis, and it also causes agony when a patient puts pressure on the area. If you're a doctor or the patient sitting in front of you, how do you tell the difference between pudendal and obturator neuralgia without just opening them up to look?
It's a really important distinction, and it comes down to tracing the specific neuroanatomy. While both conditions cause immense pain that can be aggravated by sitting, they govern entirely different territories of the body. Simply put, the obturator nerve does not innervate the genitals.
Okay, so that is a very clear, hard dividing line.
Exactly. Pudendal neuralgia is caused by compression of the pudendal nerve, often in a different anatomical tunnel called Alcock's canal. That nerve supplies the clitoris, the labia, and the anorectal area. So if a patient's primary complaint is severe genital pain, the pudendal nerve is the prime suspect.
Right.
But if a patient comes in with deep aching pain isolated to the upper inner thigh that shoots down toward the knee, the clinical compass immediately points away from the pudendal nerve and directly toward the obturator nerve.
So once a doctor suspects the obturator nerve is the one getting crushed in this mesh tug of war, how do they definitively prove it? I mean, we're talking about microscopic nerve fibers buried deep under layers of muscle and fascia.
The diagnostic process is fascinating. It requires mapping the nervous system from the outside in, and the very first step is a focused physical exam where the doctor checks sensory dermatomes.
And for anyone unfamiliar, a dermatome is basically a geographical map or a zip code on the skin. Like every nerve in the spine is responsible for a specific zip code on your body.
That is a perfect way to visualize it. If the doctor tests for sensation and finds numbness or altered pain responses specifically in that inner thigh zip code, they know the obturator nerve is compromised.
That makes sense.
Following the physical exam, they'll order high-resolution imaging, like an MRI or a CT scan of the pelvis.
But wait, a standard MRI can't actually see a microscopic nerve getting pinched by scar tissue, can it?
No, it cannot. The purpose of the MRI at this stage is really to look at the macro scale. The doctor needs to rule out other large, dangerous masses that could be compressing the nerve. Things like a pelvic tumor, a large cyst, or a hematoma.
Okay, so ruling out the obvious stuff first.
Right. To look at the micro scale, they rely on an EMG or electromyography.
And how does an EMG measure the health of a nerve?
Well, an EMG involves inserting tiny needle electrodes into the muscles innervated by the suspect nerve. It measures the electrical conduction. Think of it like testing a wire's electrical resistance.
Okay.
If the nerve is healthy, the electrical signal fires quickly and cleanly to the muscle. But if the nerve is trapped or damaged by scar tissue, that electrical signal will be delayed, degraded, or sometimes absent entirely.
Wow. But even with an abnormal EMG, the sources say the true gold standard for pinpointing this exact pain source is the ultrasound-guided obturator nerve block. Let's walk through the mechanics of how this block actually works in the clinic.
Sure. So the physician uses an ultrasound machine, which bounces sound waves into the tissue to create a live, real-time image of the muscles, blood vessels, and nerves. Watching a monitor, the doctor carefully guides a needle through the thigh, aiming precisely for the space around the obturator nerve.
Sounds incredibly delicate.
It is. Once they are in position, they inject a local anesthetic, typically lidocaine or bupivacaine.
Kind of like getting an intense numbing shot at the dentist, but delivered deep into the architecture of the pelvis.
Exactly. And this injection serves a dual purpose. It's both therapeutic and diagnostic. If the doctor bathes that specific nerve in numbing medicine and the patient's pain completely vanishes for a temporary window of 5 to 8 hours, it's considered a positive test.
Oh, wow.
Yeah, they have definitively isolated the culprit. By temporarily turning off the signal from the obturator nerve, they prove that the obturator nerve is the sole source of the pain.
I mean, just having someone definitively prove where the pain is coming from after years of being told everything looks normal has to be a monumental relief for these patients.
Absolutely.
But a 5-hour window of relief is not a cure. How do you manage a nerve that is constantly being irritated by a permanent piece of synthetic mesh?
Well, the clinical guidelines mandate, starting with conservative management, the very first step is load management. This requires the patient to temporarily cease activities that actively stretch or compress the pelvis, such as prolonged walking, running, or single-leg exercises.
Essentially trying to reduce the mechanical friction on the nerve to lower the baseline inflammation.
Exactly, giving the angry tissue a chance to stop actively swelling.
Makes sense.
Following that, they introduce progressive adductor loading. Because remember, the adductor muscles of the inner thigh rely on this nerve. If the patient does nothing, those muscles will atrophy. So physical therapists will use pain-limited isometrics.
Meaning they activate the muscle without actually moving the joint, like sitting in a chair and gently pressing your knees inward against a stationary ball.
Oh,
You engage the tissue, but you don't stretch the nerve.
right. It safely reloads the muscle without changing its length, preventing flare-ups.
See, I need to ask about a specific physical therapy technique here. Because if you have friends who have dealt with sciatica or pinched nerves, sports physical therapists often prescribe this aggressive stretching called nerve flossing.
Oh, yeah.
They have the patient do these sweeping leg movements to pull the nerve back and forth, trying to break it free from tight tissue. Would nerve flossing work to break the obturator nerve free from the mesh?
No, absolutely not. The clinical sources issue a strict, explicit warning against this. Aggressive nerve tensioning or flossing is absolutely contraindicated in the irritable phase of obturator neuralgia caused by mesh.
Why is it so dangerous in this specific scenario?
Because the symptoms here are driven by chemical inflammation and a rigid tether, not just a simple muscular tightness. Fibrosis is dense, inflexible scar tissue. The nerve is already highly reactive and physically glued to this rigid wall of mesh and scar.
Oh, geez.
Yeah, if a therapist tries to aggressively stretch or floss it, they are literally grinding an inflamed nerve fiber against a rigid synthetic barrier. It will cause massive microtrauma and make the pain exponentially worse.
Wow, that perfectly explains the nightmare scenario of the Yale patient who could only endure 2 weeks of therapy. She was likely doing stretching exercises that were actively shredding the nerve against the mesh.
Most likely, yeah.
So if physical therapy is a dead end or actively harmful, what is the next intervention?
The next step on the ladder is targeted steroid injections. The doctor uses the same ultrasound guidance to inject powerful anti-inflammatory corticosteroids directly around the nerve, hoping to suppress the localized immune response.
And if that doesn't work?
If steroids fail to provide lasting relief, they move to a procedure called radiofrequency ablation, or RFA.
Right. What are the physical mechanics of radiofrequency ablation?
Well, the physician guides a specialized hollow needle down to the obturator nerve. Once positioned, they pass an electrode through the needle and use radio waves to heat the tip. They intentionally heat the tissue to essentially burn or stun a small section of the nerve fibers.
That's incredible. It's less like flipping a switch and more like physically cutting a phone line.
Yeah,
The pain signals just cannot reach the brain because the hardware itself has been intentionally damaged. But wait, nerves have the ability to regenerate, right?
they do. The body will slowly splice that nerve fiber back together over time, but the ablation provides the patient with a very solid block of pain relief for anywhere from 6 to 12 months while that regeneration happens.
So it buys them a year of their life back.
Exactly.
But fundamentally, it's still only treating the symptom. The underlying cause, the rigid mesh heavily scarred into the pelvis, is still there. If the pain is directly tied to the mechanical tension of the mesh, at what point does a surgeon just have to go in and remove the device?
Well, when conservative measures fail and nerve blocks confirm the source of the pain, surgical removal becomes the necessary, albeit highly complex, solution. The initial decision a surgeon faces is whether to attempt a partial removal or commit to a complete extraction.
What dictates whether they can leave part of it in?
It depends entirely on the geographical location of the pain. If a patient is primarily experiencing vaginal pain or localized pain during intercourse, a partial removal might resolve it.
How does that work?
The surgeon makes an incision in the vagina and cuts away the central 5 to 6 centimeters of the mesh that sits directly under the urethra.
Wait, if the ultimate goal is to release the tug-of-war tension across the pelvis, why not always just snip the central vaginal portion? I mean, if you cut a tightrope in the middle, the tension immediately drops to zero on both ends. Why go digging deep into the groin?
It's incredibly logical to think of it like a simple tightrope, but human tissue behaves very differently. The mesh doesn't just sit in empty space, it becomes thoroughly embedded in fascia.
Fascia.
Yeah, fascia is the tough, fibrous connective tissue casing that surrounds every muscle and organ in the body. Over a decade, the mesh arms in the groin become permanently glued into the obturator internus muscle and its fascial casing.
Oh, I see.
Cutting the middle of the sling releases central tension, sure, but the arms and the groin are still encased in dense fibrotic scar tissue that is actively crushing the obturator nerve.
So the surrounding scar tissue itself has become the permanent trap, regardless of whether the other end of the mesh is attached.
Precisely. If the patient has groin pain in addition to vaginal pain, the entire sling must be extracted, and our sources are adamant on this point. Any surgeon who claims the entire TOT sling can be removed through a single vaginal incision is not being truthful with the patient.
Because an average sling is 14 to 24 centimeters long, wrapping all the way out into both legs.
Exactly. To remove it entirely requires a grueling, multi-hour operation. The surgeon must make an incision in the vagina and separate incisions deep in both groins. They have to carefully dissect the mesh out of the obturator foramen, peeling it away from major blood vessels and the obturator nerve, all without nicking the bladder or the urethra.
That sounds like attempting to extract rebar from set concrete without damaging the plumbing running right next to it.
It's one of the most demanding procedures in pelvic surgery, often taking between 2 to 4 hours, and timing is critical here. If a patient waits too long, the dense fibrosis can cause irreversible, permanent damage to the nerve that no amount of surgery can fix.
That's devastating.
The success rates of these full extractions really reflect the sheer difficulty. Roughly 60% of patients see a significant improvement or total resolution of their pain. About 30% remain exactly the same. The surgery doesn't resolve the nerve damage, but it doesn't make it worse. But in 5 to 10% of cases, the trauma of the extraction actually leaves the patient in more pain than before.
A 5 to 10% chance of making the agony worse is a terrifying gamble. But when the alternative is living with untreatable obturator neuralgia, I mean, 50% odds of getting your life back starts to look like a necessary lifeline.
Yes. And the severity of these complications has forced the medical manufacturing field to adapt. We are seeing an evolution in the design of these devices to mitigate that foreign body response. For instance, the development of the TVT Abrevo.
The Abrevo, designed as an abbreviated version of the original mesh.
Exactly. It's a much shorter sling specifically engineered to reduce the overall burden of synthetic material in the groin. The clinical objective is to provide the necessary mechanical support for the urethra. But by implanting significantly less mesh into the sensitive obturator region, they hope to prevent this slow-building inflammatory cascade from entrapping the nerves in the first place.
Basically, less foreign material means less immune response, which means less dense scar tissue.
Right.
Taking a step back, this entire journey reveals so much about modern medicine. We started with a minimally invasive, incredibly common surgery to fix incontinence. And we traced the biology of how, over a decade, a slow-burning inflammatory response turns a flexible hammock into a rigid calcified rope.
It's quite a process.
Yes. We looked at how that tug-of-war entraps the obturator nerve, the meticulous detective work of using ultrasound blocks to isolate the electrical signals, and, the harsh reality that sometimes the only escape is a highly dangerous 4-hour extraction surgery.
It really forces us to acknowledge that the human body is a dynamic, constantly reacting environment. A surgical intervention doesn't just end when the incision is closed. The body continues to interact with that device for decades.
And this brings us back to you, the listener. Why does understanding the deep anatomy of the obturator nerve matter? The single biggest takeaway from our sources today is the absolute necessity of being your own advocate in the medical system.
Absolutely.
If you, or someone you love, develops inexplicable burning leg or groin pain years after a pelvic surgery, you now have the physiological framework to understand exactly what might be happening. You know that standard physical therapy could be actively harmful, and you know exactly which diagnostic tests like the ultrasound nerve block to ask for.
True patient advocacy is built on knowledge. When you understand the biomechanics of how an implant from 10 years ago could be the hidden source of your current pain, you are empowered to reject dismissive answers and seek out the specialized surgical care you actually need.
It's incredibly empowering, but it also leaves me with a lingering, slightly unsettling question to mull over. When medical devices, like synthetic pelvic slings, are rapidly designed and deployed to solve an immediate, highly distressing problem like incontinence, well, how long should we realistically track these patients to fully grasp the true physiological cost?
Right, because the clinical trials for many of these devices often only track patients for 1 to 2 years.
Exactly. If a complication requires 5 to 10 years of slow, silent inflammation to finally manifest as nerve pain, a 2-year clinical trial is functionally blind to it. It really makes you wonder about the long-term lifespan of all synthetic materials we place inside the human body. How many other modern medical implants might be silently waiting for a 10-year inflammatory response to finally tip over into chronic pain? It's definitely something to keep in mind the next time a procedure is pitched as a simple, consequence-free quick fix.